Morning, or good afternoon. Good afternoon and or good morning, everybody. It's actually afternoon where we are. My name is Mike Fox. I'm joined here. We are calling from not so warm and hopefully virus-free Cleveland, Ohio. I'm with Dr. Richard Shepler. On the list today, it was listed that we were going to be joined by Dr. Balanci from Harvard. He had a conflict in his schedule, so unfortunately he will not be able to join us. But he will be with us on our next in this series. The topic that we're going to cover today is on crossover skill sets, and so this is from a clinical perspective. Skill sets that cross over and cover very specifically mental health and substance use. But all of this is then wrapped up from the perspective of providing that type of integrated care to adolescents, which is really the primary area of focus then that we're going to interpret mental health needs and substance use needs through, and then all of that is also wrapped up into family system inclusion. So there's quite a bit that's integrated into this. But the primary perspective that we're thinking about when we are talking about crossover skill sets, because there is a great deal of anxiety that can arise out of providing integrated care for mental health and for substance use, is looking at the skill sets that we would look for on the mental health side, the skill sets that we would look for on the substance use side, how they've been traditionally viewed as being separate, but in reality, and hopefully through our conversation today, we will discover and maybe decrease some anxieties about there is a lot of overlap. At any time, like Tiara has prompted, and we tried it a little bit differently today, trying to prompt some questions beforehand so that we would be sure to hit some topics that were on your mind before we got started. But I don't think that we haven't inspired any early questions yet today. But at any point that you have those, please type those in, and one of the three of us will catch those, and we will be very sure to incorporate that into our discussion. We did have one early question that was submitted when somebody registered, and I wish I knew the person's name so I could thank you. But whoever submitted it, thank you. In terms of thinking about cultural competency and cultural responsiveness as we're thinking about these crossover skill sets. And so we will definitely address that directly and then also indirectly through a lot of the slides that we're going to cover. So anytime, type in questions, and we will weave that into this. So our learning objectives today, and if we get to all of these, great, and if we get distracted by one particular area of focus that is really resonating with folks who are participating, then that's fine too. So, but our learning objectives for the day: describe ways, structurally and clinically. So structurally, thinking about programmatically and the way that things are structured at the federal, state, and then the agency level, and clinically the way that they are applied. Treatment for youth with co-occurring mental health and substance use needs that has been separated and often been based on adult developed models. So, you know, as I was rambling on there in my initial introduction, looking at the two sides, mental health, substance use, but then also very specifically thinking about how do we apply this to adolescents, which are a very unique and purposeful period. They're in a unique and purposeful period of development that we really can't use childhood models or adult models to understand them. So identify challenges to finding clinicians willing to and capable of providing integrated mental health and substance use treatment. And I'll be willing to bet that for a lot of you that saw this topic and registered, that was really what was on your mind in terms of how do we find people that are not just ready but willing to learn this and willing to do this, because there is a great deal of anxiety about intentionally acknowledging that you're doing this kind of work. So to youth, their families, describe early strategies for developing this much-needed workforce. Outline tools to aid clinicians in understanding, framing, and conceptualizing the complexly interactive, I don't know who wrote that, it was me, dimensions for youth with co-occurring mental health and substance use needs. So when we have a workforce that we have politely convinced or coerced into providing integrated care in a more intentional way, finding tools to help them do this so that it's more comfortable and it works better for the youth and the families that we're working with. Hopefully today we can provide some of those early tools and some ideas about those early tools for integration to reduce some of that of anxiety and then also increase the clinical skill set. And then lastly, list core skill sets that are essential and common to working with youth with any needs and their families. And so then that goes even beyond thinking about co-occurring disorders, co-occurring mental health and substance use, but really the multidimensional high-level need that can be involved when more than one area is identified. So once again, just prompting everybody, think about any questions that you would have in this realm, whether it's about providing care to adolescents, thinking about intentionally integrated care, and then how that applies to not just developing, but supporting and then sustaining a workforce that is not just willing, but then ready and has the skills to provide intentionally integrated care. For any of you who have been doing this in terms of the clinical application piece really for more than, about 10 years, so any longer than that, I go back way before that. I started on the adult side, and when I started clinical work, I started in a drug and alcohol clinic, and that's all it was. We provided clinical drug and alcohol counseling services and medication services, and if a client or an individual came and there were clearly identified needs on the mental health side and expanding beyond that, but specifically for the mental health side, there was nothing we could do about that except refer them out. And when we would refer them out, nobody was interested in opening them up and starting to work with them and helping them until we had done, at least to a certain point, on the drug and alcohol side of things, because, what was the reasoning back then? You would think, well, you would hear, you need to help them get the drug or the alcohol use under control so that we can see what the real mental health symptoms are. Well, we learned and we know from experience, and I'm sure that most of you joining this today know from experience and really from where the research is now, if you just try to tackle one part of what's going on with a person, it's really difficult to initiate and then even more difficult to sustain any change because it is just one component of a lot of areas of need. So the integrated approach is far preferable, but the systems have for so long been siloed. That is each area is encapsulated into its own little area, and it is separate and doesn't mesh with or communicate with the other side. And so when therapists, counselors, social workers, helpers, case managers come into this type of work, they have been encouraged or trained really to think about things in one direction or the other. I am a drug and alcohol counselor. I am a mental health counselor, and I don't do the other side. Well, the truth is if you're working with teenagers and or adults, you're doing the other side. You may not be doing it directly or intentionally, but we know that when there's mental health needs, there's a high chance of substance use needs, and then the reverse is even more true. When there's identified substance use needs, there's a very high chance of mental health needs there as well. But when we ask people, And just about every place now does ask people, at least in the screening sense and some sort of initial assessment sense, to look for the other side, whatever side it is that the person is referred into, or whatever your area of specialty is. We are asking clinicians to take a look at the other side, so to speak. So if you're in a primary mental health agency, we're asking, well, do screening for substance use. And if there is any kind of substance use issue that is identified as possible through a screening, then we want to do a deeper look through an assessment to see what the level of need is there. So most agencies and most systems today are a little bit more inclined and ready and recognizing of the need to do that. However, because of the way things have long been established, there still is that line in between the two systems, the two systems of help, which really, as we're going to talk about, aren't that separate, but the perception there is. So the core skills that are there are pretty universal. And when we're talking about working with adolescents, there are a lot of really core skill sets that are universal to all adolescent work. There'll be a test on this slide afterwards. It looks kind of confusing, and I want to warn you, there's 3 in a row that look confusing and jumbled like this. So if you are listening and you are doing case notes to catch up, or if you're eating your lunch, or if you're staring out the window thinking about what you're going to do this weekend, I encourage you, click back and look at the screen just for a minute, because it is kind of complicated, but we're going to go through it pretty quickly. This is just a way to conceptualize the way things have been sort of integrated, the way they have been completely separated, and then a goal for complete integration, and it's just a conceptualization of that. So as things stand right now, we are at a level of semi-integration, in that if you are doing primary mental health work, or if you are doing primary substance use work, there is a recognition that we're going to look for issues on the other side. We might not be able to address those here as completely, and it might have to do some referring out, but we do know that it's important that we tackle all areas of need that are going on with an individual at the same time, so that we can promote change, and then most importantly sustain that change, because all areas of need are being addressed. Might not be able to be by the same person, might not be able to even be in the same agency, but we're going to look for it, and if it's there, we're going to at least provide some referrals. So that's our current semi-integrated approach. Right now, when we work with adolescents, a lot of times we take that developmental approach, that developmental understanding, and we apply that initially for our early understanding of what's going on. And we take a look at expanding beyond the developmental perspective of thinking about adolescence. Part of that developmental perspective is looking for trauma, either incidences, individual experiences of trauma, or the more complex long-term developmental trauma. It's easy to lose focus on that after the initial assessment period. So we do screening assessment based on what pops up from that. And then, as things are now, a lot of times places we're going to identify one area as your primary area of need. We're either going to back burner the other side, or we're going to refer you out, or possibly have 2 different clinicians in the same agency, one who's going to do the substance use work and one who's going to do the mental health work. It's parallel care. It's a big improvement over the way things used to be. It's still not necessarily ideal. So this complicated presentation is the way things used to be, and as I mentioned when I started, things were very separated this way. Working with adolescents years ago, and not that many years ago, when things were completely not integrated at all, there was not an emphasis on taking that developmental perspective or looking for trauma. Things were very much diagnosis-driven, and for those of you that do a lot of diagnosing, especially with adolescents, you know that the criteria for the diagnoses that are available to us are normed on the expectation of consistency. That is they're normed for adults. And what are adolescents not? Which is an odd way to say that, but adolescents are not necessarily consistent, and they're not supposed to be. Adolescents are practicing things, practicing the way they're going to do things, practicing the way they conceptualize things, moving towards their fully developed adult identity, but they don't have that during their teenage years. And so without that perspective, they can look like a lot of things that they aren't necessarily. And when we take a diagnosis-driven approach, they can have a lot of different diagnoses. For any of you who have worked with adolescents for a long time, there was a period, especially youth who are wrestling with multiple levels of need, co-occurring needs, they would come with a historic diagnosis of bipolar disorder, and it was really high. And you know, if you think about kind of a non-careful description of bipolar disorder, every teenager is a non-careful description of bipolar disorder. And so when it's diagnosis-driven like that, it's not very well developed, the understanding is, and it's difficult to integrate. And in this pre-integrated approach, then, if needs were identified on both sides, there are definitely substance use issues and there's definitely mental health issues. You know, the traditional way of thinking about it was you take care of any medical issues first. And from our perspective, then, that would be, does the person need to be detoxed? And previously, there was almost no detox for adolescents. After detox, then you would have to tackle the substance use issues, because the substance use issues are probably masking and exacerbating what's really going on with the mental health issues. And so before we can understand the mental health issues, substance use needs to be tackled. And then lastly, when all of that's done, then we can tackle the mental health issues. It's pretty difficult to get anywhere that way. And with the low likelihood of change on the substance use side, when you're just addressing that one side, you wouldn't get to anything else. And so, you know, and then what are the kids and the families then labeled when change isn't happening as we expect it, and they don't fit into the programs that we have, rather than fitting our programs to them? They get labeled as resistant, and they just don't want to change, and they just don't care, and so they get blamed for the poor design that's not supporting them in change. And so, you know, there's a lot of kids historically, and I think that this still happens too, that have a lot of areas of need, and if those aren't addressed comprehensively, then the youth and the family get labeled as resistant, and we tell them to come back when they're ready, rather than trying to design and individualize a non-diagnosis but need-driven approach with more of a system of care approach. So, and then lastly, and I'm going to move through this pretty quickly, this is our intentionally integrated approach, where we keep the developmental perspective throughout the entire process, where we keep an eye out for trauma and developmental trauma throughout. And not every kid has trauma and developmental trauma, but not every kid is going to be able, we're not going to be able to identify that up front, so we do have to keep our eyes and our ears open for that throughout the screening and assessment process. And really, the arrow for the screening and assessment process should have cycled back to itself on this, because when we're working with adolescents especially, we don't get all the information up front, and it's difficult to understand that information, so we have to be open to screening and assessing at any point during the treatment process and returning to that on a pretty regular basis. Combined integrated care with preferably with a single clinician that can integrate a treatment plan, that can integrate the goals with the youth and with the family, so that mental health and substance use services are provided at the same time, single clinician, and that there is a fully enveloped systemic approach that includes the family, because that's where the true support for change is hopefully going to be. So that's where we are, where we've been, and where we would like to be. In terms of the type of care that we're going to be talking about today, where we're trying to identify and then build up and provide some skills for those crossover skill sets in what we'll be asking clinicians to do. So at this point, based upon all that rambling that I just did, and the good news is you're about to hear from Dr. Shepler, who will be a lot more coherent Do you have any questions? And as this is transitioning more towards Dr. Shepler, if they're really hard questions, that's a benefit and a bonus. If they can't be answered, that's good too. But if you have any questions in terms of integrated care, adolescent perspective, trauma, developmental trauma, and how we're going to incorporate all of this in skill sets that we're going to ask clinicians and case managers and our supervisors to be doing, please add those. All right, so moving into workforce development.
All right, thank you, Mike. I will take over for the next couple of slides here. We encourage all of you not only to ask questions, but to wash your hands frequently throughout our presentation. If you have a mask, please wear it. So, finding clinicians with existing co-occurring skill sets is very challenging. So, we have a workforce issue in general, but when you start talking about a workforce that has substance abuse and mental health skill sets, that becomes even more difficult. Not impossible, but difficult. So Mike and I have worked over the years trying to figure out, what are some strategies around this then? The reality is that a few graduate programs offer coursework in co-occurring treatment. There are a few, but not many. There's a shortage of professionals in general. What we've been experiencing is the default training responsibility falls to community agencies, and specifically program clinical supervisors. So, this is often a learn-by-doing method that is coached by the supervisor, maybe even an outside consultant, with some sort of ongoing training, but it usually happens at the community level. So, what do you need? That makes the duly licensed supervisor, duly trained supervisor, the most critical part of any program that gets created, because somebody has to understand it and somebody has to teach it. You can use outside expert support. We do a lot of that. There can be some other folks that also do some of that. But what that would look like is probably some sort of quarterly targeted skill trainings and weekly to monthly consultation at the clinical level. We have found that over time that we think that hiring staff with diverse skill sets and doing cross-training within your team has been an effective method. So you might have a substance abuse expert, a mental health expert, you might have more of a kid expert, but you do cross-training within the team. You want to make sure, especially because of the complexity of the youth that we're serving, that you have protected clinical supervision time. Field supervision might be needed, so you really need to have a dedicated supervisor for this work. And then the supervisor addresses the treatment integration in terms of guiding the process. So our challenge is, how do we systematize post-service training to build the workforce from the ground up?
Okay, before we move to the next slide, I do want to acknowledge Sarah has asked a question. Thank you, Sarah. As a parent support provider, how can I help families understand the importance of this approach? And it's a really good question, Sarah. How do we get this across to parents that it is important to provide fully integrated care, because the family partnering in this is, from the perspective of the way we do things and the way that we conceptualize things, the family is the most important partner. And it's easy to lose track of that sometimes. Hopefully, as we go through this, Sarah, we're going to give you some resources in terms of understanding that, and then at the end, if there haven't been the direct resources for that, I'm going to encourage you to email me, and I'm going to send you a list of resources in places that are really designed for parents and consumers. So it's a little bit less clinical speak oriented, and it's a little bit more consumer oriented, and some of those, I'll give you a link to some of those sites. One of the great ones just off the top of my head is NCTSN, the National Child Traumatic Stress Network, which sounds maybe like it's kind of a sidestep because that's just one piece that we're talking about, but they do have a very comprehensive list of resources and things that are designed very specifically for parents to understand. And I would be remiss if I didn't also acknowledge SAMHSA. SAMHSA's site is just so big and there's so much stuff on it that sometimes it's difficult to navigate. But there's so many good parent-oriented, family-oriented, and community-oriented resources. So, and hopefully we'll be a little bit more specific about that.
So, thank you. And Sarah, I'll just add a few things, and that is, number one, I mean, one of the selling points of integration is that families only have to tell their story once instead of 2 times, or 2 times or 3 times, and things like that. That's one thing I would be sharing with families. But I would also share what Mike said, which is we can't do this work without the support of the families and the caretakers. So, you know, our approach is creating recovery environments for the whole family so that we can help the youth be successful. And they're critical experts of their families and critical partners. I would even go as far to say is that not only parents, but young adults as well, you need mentorship and you need recovery support partners at the end if you're going to make this work. So treatment is one piece of it, but ongoing support for the young person with somebody they can relate to who's also in recovery is an important piece. All right. So take-home points. Integrated skill sets are multifaceted. Skills need to be comprehensive enough to meet the complex needs of youth with co-occurring disorders. No one has the complete skill sets when hired. None of us. And that's okay. We just need to start going there, that it's fine, and what do you need? So a good assessment up front is going to be important of the person you hire and what their skill sets are. Skill sets are built through application in the field, and then supervisors play a key role. We will next talk about some of the strategies and tools we've developed over the years, and hopefully that you might find them helpful as well. As we said earlier, the youth that have co-occurring disorders present with what we call multiply occurring conditions, right? There could be developmental issues, there could be intergenerational trauma, there could be more than one mental health diagnosis, there could be more than one substance use issue as well. And to keep in mind that youth that have co-occurring disorders are at higher risk of suicide attempts and suicide ideation. So there's so many risk and safety issues, but also variables that you need to account for when you're building up your integrated plan. That's important to do a good integrated assessment. And Mike and I are good at developing complex slides. The reality, though, is you can't represent the complexity without being a little complex about it because there's so many variables. So we like to do a comprehensive perspective. We look at the interactive aspects of trauma, risk and resiliency factors, developmental factors, safety concerns, all the contexts which the youth lives and functions in, whether that's home, school, community, peers. We look at all the diagnoses for both the youth and the family because it becomes important that we factor in those things as well. And we put this into basically what we call an interactional contextual functional analysis. Because we thought at least 4 words would be big enough. But here's the other reality. All the child serving systems, maybe except mental health, for a long time have always done functional analyses, right? The school does them. They call them FBAs, functional behavioral analyses. Developmental disabilities do them. Substance abuse has been doing them forever. So why aren't we doing them in co-occurring in mental health as much? We're seeing them being utilized a little bit more in mental health because programs like multisystemic therapy, they use something they call the FIT circle, which is in a sense a functional analysis. DBT uses chain analysis, if you will. So everybody has a slightly different name. So we thought we'd come up with another one. But we do think it's important. So there are many variables that may tie into why did this behavior happen at this time. And if we don't think complexly enough about it, we might miss stuff. And we don't really want to miss stuff.
Yeah, and I want to add to that too. As Rick mentioned earlier, talking about the specific workforce that we recommend and really like to have when we can find clinicians and providers with a diverse range of experiences and skills. This then ties into this type of conceptualization, but it does require that we do put some time and protect some time for the team to come together as a team. Even if we're not taking a team approach, the team of our providers, where it will allow a provider to present the case in this very complicated fashion, trying to take a look at all of these different areas, these different factors, and then getting some input from people who have some different areas of expertise, some different knowledge about what's available in the community and what programs are there, and really how to understand adolescents and families and the interactive pieces to that. So it's one of the areas of challenge with workforce development, in that because it is so complex, and because when we're talking about youth with co-occurring disorders, the risks go up considerably, and really not recognizing those really increases the risk. When we recognize those, it does help the youth and the family decrease those risks. But part of the challenge is then we do have to have some non-billable time set aside where we can come together as a team and increase our understanding. And that is, I understand that's challenging.
To piggyback on that, we also find that diagnosing youth is really hard because kids are growing into their stuff, whatever that stuff is. They're either growing into their drug use patterns, they're growing into their mental health patterns, and we think it's actually kind of hard to do, and we also think that's okay. It's okay not to know. It's okay to figure it out as you go along. I'd rather have that openness to a variety of options rather than to say, oh, for sure, this child is blank and blank. I don't know that that's all that helpful. So we have worked on developing tools and or using other tools and making them more integrative over the years. This is a integrated timeline. One of our older colleagues, Eric Baltrinik, started utilizing this, and we have put some more into it. And all it is a timeline from birth to now, based on what are the mental health symptoms that you're seeing at those ages, what are the substance abuse symptoms you're seeing at those ages, what are the developmentally important factors that play into that, whether that's risk and protective, trauma, brain development, okay? Because those things help us get to that differential diagnosis, if you will. And even if we're not using the word diagnosis, it helps us understand the youth better. And the better we can understand the youth, we can actually not only address the issues, but I think it really helps us be a whole lot less judgmental about what's going on. It's like, okay, so here's what's happening. Let's talk about what we can do differently, et cetera. So one of the tools we have to Unpack the Complexity is an integrated timeline, and this is what it looks like. We showed you the integrated contextual functional analysis. Next, we're going to move to dimensional contextual map, which Mike will give us as he pushes the button. And here it is.
All right, so this is an expansion of some of the conceptualization tools that we've already introduced. The integrated timeline is a really nice piece for understanding, not just clinically, but also in engaging the youth and the family and understanding what's going on. And one thing that we talk about quite a bit as we go through a lot of the tools that we use in the different programs and the different program consultations that we do, that none of the tools that we have are double secret clinical, this is just for us kind of stuff. This kind of stuff really helps the youth and the family understand a lot more. And you don't have to have, the color slide that you print out with room to write on. All you need is a conceptualization in your head of how you would like to frame things, and a piece of paper and a pencil, and the youth and the family, either in combination or separately, and just start helping them unpack these things and conceptualize them. And this is this slide with the circles and the arrows here is one of the ways that we use quite a bit to help understand clinically, and then also help the youth and the family understand the very complex nature and the interactive, and really when we talk about complexity, that's what we're talking about, is that interactive complexity. Because one influences the other, which influences backwards, and then they all influence forward. So, you could have arrows going everywhere, and the mental health influences substance use, and substance use influences mental health, and the combination of those influence how the kid is doing in school and getting along with such and such teacher, and what friends they have, and reactivity at home, and then that feeds back into mental health. So the more that we understand these individual areas of action and activity and complexity, the more we can help them understand the patterns that are there, and that's what a functional analysis really helps us and them do. And then it can also help us figure out where they are with them in terms of the skill level that they have, so that we can then start helping them match strategies to initially stop the loss of resources that are going on, and then start building on top of that. So as we conceptualize it, we take a look at the youth in the middle, and the youth has areas of resilience and strength, and then there are also areas of risk, and that can be influenced and associated by the substance use that is there, any of the mental health needs that are there. Safety could be expanded to the point that it encompasses all of these bubbles, because that is the underlying and overlying perspective of everything that we're talking about. And then there is the multi-system involvement for the youth, him or herself. And then with feedback back and forth, in that one influences the other, there's the broader community that can offer areas of resilience and strength, but then can also present risks for the youth and the family. The school, same thing. Family, it is the biggest dimension. Unfortunately, a lot of the really highly involved, complexly needed youth that we work with, there are some significant deficits on the family side, and helping them stop resource loss in that particular dimension then can go a long way in helping build all the rest of this. So, and then peers of all the bubbles up here, interestingly, peers are the most difficult to help the youth recognize that change would be beneficial there, and then also to initiate any change. Peers are the most resistant, not the individual peers themselves, but the perception of the youth that we're working with. Just if you have a teenager at home, go home and tell your teenager, I don't want you seeing so-and-so. It's human nature. Any of us, if we tell an adult that I don't want you seeing Rick anymore, well, suddenly I'm going to have a desire to see Rick more.
So if I say to you, Mike, or somebody says to you, don't see Rick anymore, that would get you into the office more often then?
No, actually, I would agree with that.
Okay.
But that's the exception, not the rule.
All right. So just to...
you want to go back?
Yeah, go back just a minute. So let's give an example real quickly. So we have a kid who, let's just make it, marijuana. He's using a lot of marijuana with his peers. The peers are out in the community probably doing some things that we don't want them to do. The family are beside themselves. They don't want the kid using or out in the community. Let's make it vandalism for the sake of this made-up intervention. And the kid's not going to school. Well, you're presented with something like that, and what you have to start doing is unpacking where do you begin when there's so much going on. And we utilize the contextual map in that way. I mean, the first step might be supporting the parents and supporting and building maybe a supervision monitoring plan. Working on maybe doing a strengths culture discovery with the family and the youth to find out what the youth does well at, focusing on resiliency factors. How can we get that youth more involved in positive activities with positive peers, right? Instead of getting into that battle of the fight you can't be with them, giving them some positive alternatives. Maybe there's a wraparound meeting or a meeting with the school to develop the positive ally at the school who the kid can connect to. So what we do with this map is we actually ask clinicians to bring it into supervision, and we start unpacking it and trying to make some of the solutions one at a time and more simple because it's so complex. And that's just an example of some of the things we might do with a family that and a youth that presents like that. Okay, we want to give you some terminology that really elicits interaction, if you will. And so we like the word mask. It hides or covers or disguises a certain symptom. Substance abuse might imitate as a crossover symptom. So if a youth is using amphetamines, but they look quite impulsive and their motor never stops, I mean, is it ADHD? Is it amphetamines? You have to start doing your differential. But some of these things mimic. It might activate or trigger. All right, so you might have a trauma effect, a trauma trigger that activates depression that may activate use. You might have a mental health symptom that attenuates, let's say a substance use issue that attenuates or alleviates some of the emotional pain. It might intensify or amplify one or the other. So what we're saying here is that these words, if you put mental health and or substance abuse at the beginning or the end, you're describing how one affects the other. And we wanted to give you some language to utilize around that. And the rest are obvious, where they're just listed: prolong, exacerbate, diminish. Emotional numbing, that could be using alcohol to numb trauma symptoms, for example. So this is the language we use. We'll give you some examples here. Substance abuse impact on mental health. It may attenuate mental health symptoms like, for example, marijuana's effect on aggression, which is what we've seen. We've actually had some families tell us that, we like him better when he's using because he doesn't put holes in the wall, which creates another set of issues for you in terms of how do we create change in a family where that dynamic exists. Increase, escalate, intensify mania symptoms. Cocaine will do that. decreased self-control, increased impulsivity. That could be alcohol, mania, ADHD, externalizing disorders. It could help uncover a pre-existing condition use. So we know that marijuana, at the current research, and K2 and synthetic marijuana may uncover a predisposition to psychotic symptoms. And they show up with marijuana use or synthetic marijuana use. And emotional numbing, as I said, marijuana, alcohol, and trauma would be a good example of that. So these are some examples. I'll give you one more set here on mental health impact on substance use. ADHD, impulsive decision-making and poor judgment with ADHD may accelerate substance use. We find that quite often, whether it's alcohol, cannabis, or other drugs. Anxiety or OCD. And I just want to give everybody a reminder that it's now time to wash your hands again. Sorry. Increase in anxiety might lead to substance use to alleviate the symptom, whether it's alcohol, marijuana, benzos, other calming agents. In terms of depression impact on substance use, increased depression influences the frequency and intensity of alcohol use for the purpose of numbing some of the depressive symptoms. And mania, interestingly, persons use cocaine to expand the symptom because they like the symptom.
Yeah. And a lot of communities right now are seeing the national statistics and the work that we do really hasn't shown a lot of adolescent cocaine use, but something that is really starting to make an unfortunate comeback is methamphetamine. And methamphetamine is mania on steroids. So it's something that I suspect some of you are already seeing or have heard about in terms of methamphetamine seems to be coming in and filling some of the void from the fright that is there and rightly associated with opiates and narcotics. So, and you know, when you're working with adolescents, it's you see different cohorts use different things, and so our adolescent cohort, our group of adolescents, and really up into young adulthood, are using smaller amounts of opiates than they have in recent years because they have seen the damage that it has done in their families and in their communities. And so you'd hear from teenagers, no, I'm never going to do that, that's stupid. But unfortunately, human beings being human beings doesn't scare human beings away from using drugs, it just has them use something different. And methamphetamine is coming back in where that vacuum has left. With kind of a pullback a little bit. Opiates are still there significantly, but coming back in to fill as those are pulling back a little bit. And some of the others that are mentioned on here, if you work with adolescents, and this really then gets into helping our clinicians and our caregivers recognize when they're working with adolescents. This is I think Rick put this page together, and it's really well put together in that it identifies the big areas for adolescents. The most common mental health area of diagnosis that co-occurs with substance use is ADHD, followed very closely by the ever-popular ODD. But ADHD is at the top of that list in terms of co-occurring on the mental health side. But for adolescents, the overwhelmingly large, most common area of symptoms, not crossing the threshold into actual disability. So, you know, the threshold we would use hopefully for a full diagnosis, but symptoms that if they were an adult, we would probably diagnose this, is anxiety. 50% of all adolescents have a lot of symptoms of anxiety. That if they were adults, we would say that they have an anxiety disorder to some level. But that's part of the adolescent experience. But that is so common, the symptoms of anxiety. So that's really part of their consciousness. In terms of crossing that threshold into disability, into having that severe emotional impact, Depression slightly leads anxiety in terms of that level of severity. So these are really the big areas on the mental health side that you will see working with adolescents. Symptoms of anxiety, a lot of depression, and working with adolescents that depression doesn't look like depression that you stereotypically to think about it. Adolescents express depression in different ways than adults do, and so that takes some experience working with them, and then the impact and the back and forth impact of drugs and alcohol on that. So.
And I'm going to go over here just another example of what we do when we're trying to unpack this, and this could be done in supervision, consultation, and as Mike said, even, this is a good this is a good process to utilize with the family as well. It's like walking back the symptom, if you will. There's all kinds of different interactions. In the first example, there's a mental health symptom, we'll call it impulsive decision-making and poor judgment. That serves to accelerate substance use, let's call it alcohol for the sake of this example, which interacts with parent trauma-based reactivity, and so there's a big parental reaction to the child's use, resulting in an escalating conflict or relationship issue. The youth responds by running away, and then you have a safety risk issue. So we really believe strongly in unpacking through pattern sequencing like this. Then it's just a simple interview. And, okay, after that, what happened after that? And then what did you say? What did he say? What did you do? What did he do? Or you can work backwards. And you start to unpack the components of that. I'll give you another example. Development times functioning, interacts with functioning. An unidentified lagging skill set, a developmental lagging skill set, and unrealistic school expectation about what the child can do results in poor school performance and frustration and shutdown, leading to truancy, which leads to, I'm going to hang with the other kids that aren't going to school, and we're going to use cannabis together.
I think teenagers are saying that now these days. Let's use cannabis together.
Is that how they say it?
I think that's how they say it.
Oh, okay. Thank you, Mike. Mike has a deep and profound respect for me, and you can tell that in our, and Sarah's laughing at your joke. That's great. That's great.
Thank you, Sarah.
Okay. Hey, Tiara, I'm just wondering, I mean, can the participants use emojis and or, kind of GIFs or something? That would be kind of fun. Yeah, they can just send us something that would be kind of funny. No, okay. No. Okay. So another example, hanging with negative peers and impulsive decision-making, development in context, result in substance abuse, which may result in illegal behavior in the community, a toxic parent reaction, which is, an angry conflict happens, and the child reacts to that by doing self-harming behaviors. So these are just some examples of what could happen and how we try to unpack it, because once you unpack it, then you know where you can start to influence change, find out who's willing to change, number one, and then what kinds of things can we do to impact that change and which variables.
Yeah, and I think it's worth mentioning with a lot of the programs we work with, they are working with kids and families who are this isn't the right way to say it, but I'm going to say on the higher end of need, that they have needs in more areas than not. It's not just I'm a little bit depressed and smoking the cannabis, just a little bit. It's areas of a lot of family reactivity and then reactivity that's expressed at school and peers. So, and reactivity really does seem to be one of the most common threads in a lot of the programs that we work with kids who have needs in a lot of different areas. And so, and that was a thread through Rick's unpacking here. And in terms of helping family recognize that reactivity, and a term that you would use previously was intergenerational, and I think that is something that is very strongly intergenerational, is high levels of reactivity, because everybody's just kind of done but they're always kind of done. They're always, up to here. So
we have new nicknames apparently in our chat box. We are now referred to as Click and Clack.
Oh, very nice. Thank you. I
want to recognize Jeannie Wilsey for that.
And I'm going to claim actually being Ray Magliozzi. You can be Tom.
Okay, thank you. I've forgotten what that means, but I'm sure that that's not great on my end. Okay, next.
No, actually, it's not bad. They were the car guys.
The car guys, yeah, on NPR. All right, so I'll do the slide, and then we're going to turn it back over to Mike. So let's talk about those crossover skill sets. So we started thinking this through a little bit. Like, everybody's fearful. Like, if you're a mental health professional, you're fearful of doing the substance use work. If you're a substance use professional, you're not ready or don't want to do the mental health work. So Mike and I had some big discussions about, well, what are those specific skill sets? And do they already have some of them? So we call them crossover skill sets. So some will be cognitive behavioral interventions. Most folks are trained in some sort of cognitive behavioral intervention. Most mental health professionals and now substance abuse professionals are trained in trauma-informed care, but also interventions. All of those can be used in substance abuse treatment. Family interventions, mental health is strong in that, but we also know that the best substance abuse treatment in terms of evidence and research are family therapy interventions. Risk and safety planning and management, again, another crossover skill set. If you're just a substance abuse, if you are a substance abuse provider listening to this conversation, think about, of the mental health skills, do you already have some of these? What about resilience promotion? Well, that's another name for pro-social activities and pro-social peers. Problem solving, emotional regulation, they should be in both skills. Substance abuse providers frequently do the skills on the right, but mental health might already know how to do these. So a functional analysis, motivational interviewing, which is big now in all programs and providers. Peer interventions, pro-social. With the advent of multisystemic therapy and FFT, the hallmark of many of these evidence-based programs for kids with externalizing disorders is increased supervision and monitoring, and increased pro-social peers and supports, as well as pro-social structured activities. So you can see here, the thing that probably doesn't exist in mental health that exists in substance use is planning for a recovery wellness plan that's ongoing for the substance use. And some of the psychoeducation that's specific to substance use. But that can be learned fairly quickly, and it's not scary to learn that, all right? And then underlying everything is development and obviously context and cultural competency. And I would argue that if folks aren't trained or doing work that's culturally competent, they certainly need to be trained in it and or supervised in it.
Yeah, and I think that relates very directly then to the clinician, the therapist, the helper's ability to form a relationship with the youth and with the client. And without that, then it's going to be very difficult to help them start, identify areas of need, and move towards change. So,
the only other thing I would just point out here, just because of our original question, keep in mind when you're doing culturally competent work with youth and families, the youth's culture may be different than the family's culture. And the youth might see things quite differently, and that could be part of the clash. So I just want to put that out there. And I would also argue that families who have mental illness generationally or trauma generationally, it becomes embedded in the culture of how they exist and function as a family. So keeping those things in mind as well.
Yeah, no, that's a great point, because that very much is then part of the self-identification. It's not, oh, we have trauma, oh, we have intergenerational difficulties. It's who we are.
I know it was a good point. Thank you.
Yeah, Rick is my boss, and it's in my contract that I have to throw out a compliment once every half hour, or I pay penance. So
True.
So some of the things that overlap in terms of really basic skill sets that Rick had mentioned, and we're going to flesh these out just a little bit, but quickly. We're scheduled for 90 minutes today. We're down to about 20 minutes left. And I do want to make sure that there's some time for questions. So we're going to talk about...
A minute.
A minute.
A minute for questions.
I'm not going to use the whole 20 minutes.
Okay.
And if I'm not interrupted, then I'll use even less time.
Okay. Point taken.
No, that was very much in the spirit of click and clap. So I want to run through these. We're not going to do the wrap-up slides, which honestly were just a pet project of mine anyway, and they probably would have bored you all to death. If you download the slides and you look at them and you're nerdy enough to say, hey, that looks really interesting, and I say nerdy in a complimentary way, by all means, reach out to me, and I will, be happy to exchange nerd talk about the crossover skill sets that we're starting to develop based on some SAMHSA stuff. So that being said, if you want to take a look at the end of it, by all means do that and reach out. But some of the areas that really help clinicians on both sides. The first one you are probably familiar with a component of from the trans-theoretical model, thinking about how people change. And that was what the trans-theoretical model was about. The part that most people are familiar with are the stages of change. And this has, for a long time, been most closely associated with the drug and alcohol side of things, but it fits with every single area of potential change for youth and families. On the mental health side, and then when we take a look at all of the different dimensions around that youth, it can be on the school side, the probation side, everybody comes at the same problem with a slightly different take on their readiness to change. And we think about where is the ambivalence, is it there? So if you think about something like cannabis use, marijuana use, a youth may be very, very strongly pre-contemplative in their stage of change and their readiness to change about their marijuana use. If God gave us marijuana, it grows out of the earth, it's natural. If it wasn't for marijuana, I would put more holes on the wall, I would be more depressed, et cetera, et cetera. So very, very strongly, purposefully pre-contemplative about it, where the parents are, as Rick mentioned, maybe they're a little bit mixed, a little bit ambivalent about it. Yeah, we don't want to see her continue smoking weed all the time, but she is a lot more easy to handle when she's smoking weed. And maybe there's a probation officer who is very, very action-oriented in terms of, no, you will provide negative urine screens, and that is all there is to it. So, a single area of focus, that is marijuana use, and then all the different dimensions around the youth have different readinesses and different thoughts about readiness to change. So traditionally, we think about applying stages of change on the drug and alcohol side, but it fits just as smoothly and just as nicely and just as usefully in terms of helping to match where they are in terms of the readiness to change to the right treatment approach on the mental health side, and then in the different dimensions, on the school side, on the peer side, on the family side. So, if you think about depression, I don't want to feel depressed anymore, but some symptoms of that, I'm cutting, and cutting is what really, really works for me, and so I'm not going to think about changing that. And and everybody has a different stage of change, a different readiness to change, around that area. So the stages of change apply pretty smoothly across all the different dimensions.
And while we're on the slide, I just want to point out that one of the aha moments that Mike and I had over the years is that just because a youth may be in a purposefully pre-contemplative stage does not mean that there's not work to be done, okay? And all that work doesn't have to be about trying to get the youth ready to change, because you only got so much time and they might not be ready to change. But the parents might have some readiness to do some work. And what would that work look like? Again, doing a family-based model for change is going to open up all kinds of additional avenues for you with that youth and with that family, especially if the youth is in pre-contemplative phase.
Yes, and in terms of thinking about where the clinicians are, if they're not comfortable working on one side or the other, I'm not comfortable doing the mental health stuff, or I'm not comfortable doing the substance use stuff, this is very much a crossover skill set, and the language is the same on both sides. So motivational interviewing, just like stages of change have very long been associated just with the drug and alcohol side of things, the stages of change have also been very strongly associated as a piece of motivational interviewing. It's not. They come from separate models, separate conceptualizations, but they really fit together really well, because you can take the stages of change and then you can match that to a motivational enhancing, motivational interviewing type approach so that you can help to bring up a readiness to change, or you can do some of your stage match treatment design, which is very, very important, and that applies across all aspects that we're talking about: mental health, substance use, trauma, everything. So the core skills, I think most of us at some point have had training in motivational interviewing, and it's one of those sneaky things where when you are, let's say you're a supervisor and you're interviewing your staff and you're polling your staff, have you had MI training? Almost everybody is going to say yes, but when's the last time they had it? It's one of those things that the skills sound really good, they make sense, and you can use some of the terminology of it. But unless it's incorporated and supported on a regular basis, we all drift back towards whatever our natural course of doing things. And motivational interviewing is one of those things that works very, very well across a broad spectrum of work with youth, with families, and with all of the collateral systems. So, the core components of motivational interviewing, and this is a gross oversimplification, but you use open-ended questions. There's a lot of affirming. There's a ton of reflecting, and then when you're not reflecting, you're doing bigger reflections, which are summarizing. That is so important with adolescents on so many different ways, because who listens to adolescents? People tell adolescents, but adolescents are starting to come into their own intellectually. And so this type of approach demonstrates to them very clearly that they are being listened to. Adolescents don't necessarily have the ability, well, not necessarily, developmentally, they don't have the ability, and depending on where they are in terms of their developmental growth, they don't have the ability to weigh a lot of shades of gray. I think that I'm mixing my metaphors, or similes, I don't know which it is. But they can't see shades of gray, and they can't hold different things up to measure them beside each other internally yet. That's some of that higher complex prefrontal cortex stuff that's coming online with them. And so when we use a lot of summaries with youth, whether it's substance-related, mental health-related, family-related, those summaries are really important to help youth start to explore possible areas of change. So motivational interviewing is one of those crossover skill sets that applies pretty widely. More about cultural competency in terms of how important and how vital it is for the youth, for the family, for helping them understand really their own conceptualization and approaching it from that direction. I'm not going to read all of these words because I do want to leave a little bit of time. In terms of building a therapeutic alliance, if you don't have the client in front of you, what change are you going to help them make? None. So therapeutic alliance really underlies all of the things that we're talking about. Some other things that are worth mentioning, some things that a lot of our practitioners have mentioned: motivational interviewing, trauma-focused cognitive behavioral therapy, the TFCBT. Solution-focused therapy works very well with youth and with families. DBT, dialectical behavior therapy, is, I'm going to say, growing in popularity from my perspective. It has always been there, but as it's applied to multi-system, multi-need youth, DBT does a nice job, especially when you're tying in areas of complex trauma. And the eye movement desensitization and reprocessing, that one I really have seen grow quite a bit in terms of recognition that people are finding that useful working with adolescents across all three of those areas I just mentioned, mental health, substance use, and trauma. So some integrated models that are out there. All of these integrative models are fairly intensive, and not every youth needs this level of intensity, but when there's a youth with multi-areas of need, multi-systemic areas of involvement and need and risk, then that is matched with a higher level of care, and these are all higher level services. There's integrated co-occurring treatment, the ICT model. There's multi-systemic therapy added in here with the contingency management component, because when there is the substance use identified, it's a well-demonstrated practice, so MSTCM. Intensive in-home child and adolescent psychiatric services, or ICAPS, and then multidimensional family therapy, which is very strictly, as the name suggests, family-focused. So,
and Mike, I just want to point out, we give you some examples because, every community offers different things. And you might not be able to get one of these that are on the list, but you might be able to get one of the other ones. The other integrated model that's out there is in the state of Washington. It's based on MST combination with DBT, which is the FIT model, Family Integrated Treatment. And they've been, that model and our integrated co-occurring treatment probably, and multidimensional family therapy in particular, are some of the more integrated of those models.
And importantly, intentionally integrated from the start.
Yeah.
Yeah.
And MST always does a solid job. Okay. Next.
All right. You know what? And that's where I'm going to end.
Okay.
My rambling anyway. I can't say actually anything about Rick's rambling, but that next piece is the one I was talking about that goes into kind of the academic nerd zone. Okay. There's a good one to wrap up with. I'm going to skip through.
And then we'll take some questions. Yeah.
To this one. And if you have questions, compliments, definitely type those in. Criticisms, wait until afterwards.
Yeah.
Yeah.
So, when we start thinking about how this could all fall together, again, we think a good integrated co-occurring provider should be able to do strong engagement, strong crisis intervention and safety planning skills, be able to focus on emotional coping, some sort of cognitive intervention and skill building. The two skills that we have found in terms of the resilience literature, actually, that promote development the best, if you're going to teach skills, are emotional regulation and problem-solving skills. And so, regardless, we see those as universal core skills to build on. Asset building, resilience promotion, more and more. Having done this work for a long, long time, I find myself, instead of fighting the problem, is building the resilience and seeing some really good results with that. And it ties really well with a solution-focused and motivational interviewing approach. We know that substance abuse research supports family therapy in general, and it's also true in mental health. So if you don't work with the family in partnership with the youth, you're missing something. And as well as, obviously, trauma interventions. Trauma is in your treatment room. In a study that we did here at Case, I didn't do it, but I'd like to take, I'm going to take credit for something I did not do. We found that 80% of the kids that were involved in the juvenile justice system who also had a substance abuse and mental health issue had trauma histories. So 80% of kids involved in juvenile justice who had co-occurring disorders also had a trauma history. That's extremely high.
Yeah, and that was traumatic experience exposure too.
Yeah.
That didn't even capture the complex trauma.
True.
So, and I think that's even bigger. And when a kid is involved, and that study I think was one of the ones that showed the deeper they go into the system. That and Teflon's study.
Yes.
The deeper they go, the more common all of these areas of needs become.
So they're in your treatment room, and you also have to have substance abuse and recovery intervention skills. The core idea here is that these kids are in your treatment room now. let's not ignore it. Let's work on it. It's not impossible. And it can be trained up, actually, with current skills that you already have. We are going to stop and see if there's any questions.
Yeah, Anne, I think, and I'm gonna turn this one over to Tiara because, well, she knows everything. I think she mentioned in the beginning that there was a place to click that you could download a PDF of this. I know that they do become available. And I think afterwards they do make a recording available, but again, that's going to be Tiara answering that. Yes, under the files box. Okay, so that's for the PDF.
And then the other will be loaded on YouTube, I guess, the recording. So you can get the full PowerPoint and the recording. Holly writes, I particularly like this graphic. Why, thanks, Holly. It's one of the ones I created, not Mike.
Thanks, Holly.
The challenge is teaching all these skills to our younger workforce. This usually takes several years. Yeah, I totally agree, actually. And that's a really fantastic point. This doesn't happen overnight. Again, it doesn't happen necessarily in the graduate or the college program. This is stuff that happens post-graduate program. It's done in the field by supervisors and the team in learning together. The other thing that I'll add to that, Holly, is it really makes it ultra important for the supervisory and team relationships to be quite supportive around learning. Sometimes we eat our young, and we can be hypercritical of things that are playing out. And we have to have those supportive environments for learning new skill sets they might not have.
Hopefully that's not the takeaway point.
Eat our young?
Sometimes we eat our young.
Okay,
yeah.
sorry.
It's about youth resiliency.
Yes.
And I do want to mention that there is, at the end, please participate in, don't worry, we're not going to ask you for more input, well, we're going to ask for input, but at the end there is a survey that is very, very useful to us and to the Institute. And so we really appreciate your logging on today and staying on today, and we'll really appreciate the completion of that survey.
So Holly says, yes, a place to fail forward. And Jeannie says, I'm interested in how completing an assessment looks on paper. So it's a really good question and comment. What I'm going to say is when you begin to implement integrated work, you need to adjust your paperwork so that you have integrated paperwork. So you want one assessment with one treatment plan that addresses these crossover symptoms and goals that you're going to need to put in there. It doesn't have to look crazy complex on the one hand. On the other hand, in your assessment and in your treatment plan, you want to make sure there's interactive language in it.
Yes.
So that you're addressing the interaction as well as the symptoms.
Yeah, and it does, and who mentioned it popped up out of the screen that it takes a lot of time, and it doesn't have to look complex, but the development is. So and the simpler it is for the kid and for the family to understand, to operate, and to measure, the better. But then the language does have to have that integrated piece that does take a lot of practice and support.
It really does. And I mean, when I first started out, and we were, there was a family therapy was huge back in the day. And somebody taught me that it takes at least 10 years to become a good family therapist. And I think, yeah, that's probably right. Well, it takes a while to become a good co-occurring therapist as well.
Yes.
And learn the language, and the documentation of it has its own level of complexity that needs to be taught as well. So that's a great question, Jeannie. Thank you.
Yeah, thank you all for your input and comments. And I put up this last slide if you do have questions or comments. Dr. Belanci was not on today. If you have any questions or comments, there's nothing that Dr. Belanci can't answer. But specific to what we were talking about today, Dr. Schepler and I, it just has our names. It doesn't have our contact information. It's somewhere in there. I know our contact information is somewhere in there.
If the simple one on this one is just put richard.shuffler@case.edu. So it's case.edu. Are you michael.fox@case.edu?
I am not. No, don't do that.
So don't do that. There's many Michael Foxes in the case, so you have to be careful. So just email me and I'll send it on to Mike. richard.shuffler@case.edu.
That one's easy. Yeah. So, and I think the contact information is there. It might be in the beginning.
There it is.
So, okay.
All right.
Thank you. And so that's it. Again, thank you all very much. I hope you have great weekends and that you stay healthy. And please stick around to do this.